The causes of dilated cardiomyopathy comprise or a part of generalized systemic disorders, often leading to cardiovascular death or progressive heart failure related disability. The European Society of Cardiology (ESC) chose a clinical and morphological classification, reporting cardiomyopathies are myocardial disorders in which structure and function of the myocardium are abnormal. In the absence of coronary artery disease, hypertension, valvular heart disease, and congenital heart disease sufficient to cause the observed abnormality. So cardiomyopathies divided into hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, restricted cardiomyopathy, and some unclassified cardiomyopathies, subclassified as familial or genetic and non-familial or non-genetic, and again subdivided into unidentified gene defect or disease subtype and non-familial into idiopathic or disease subtype. The current definition of dilated cardiomyopathy is relatively simple. It is a heart muscle disease characterized by left ventricular LV or biventricular dilatation and systolic dysfunction in the absence of either pressure or volume overload or coronary artery disease sufficient enough to explain the dysfunction. This definition has been recognized as overly restrictive, as left ventricular hypokinesis without dilatation could be the initial presentation of dilated cardiomyopathy. Typically, in the 1980s, the average survival rate was approximately 50% in a 5-year follow-up, but nowadays, at 10 years follow-up, the survival-free from transplant rate is far beyond 85%. This improvement in outcomes is fundamentally due to early diagnosis, a better characterization of etiological factors, medical management for heart failure, and device treatment like implantable cardioverter defibrillator for sudden cardiac death prevention. The causes of dilated cardiomyopathy comprise genetic, primarily dilated cardiomyopathy, or acquired factors, secondary dilated cardiomyopathy. Acquired factors include infections, toxins, cancer treatment, endocrinopathies, pregnancies, tachyarrhythmias, and immune-mediated diseases. 5 to 15% patients with acquired dilated cardiomyopathy harbor a likely pathogenic gene variant, that is gene mutation. Therefore, the diagnostic test and the therapeutic approach should always consider both the genetic and acquired factors. The clinical spectrum of dilated cardiac myopathy is very wide, consisting of preclinical and a clinical phase. Preclinical might include non-cardiac expression, that is, genotype may be present but no expression of the phenotype, and also isolated ventricular dilatation. Clinical phase include arrhythmic cardiac myopathy, mildly dilated cardiomyopathy, and dilated cardiomyopathy with severe ventricular dysfunction. Moving on to epidemiology, the epidemiology of this condition is quite complex due to misdiagnosis, continuous reclassification, and changing definitions. Furthermore, since investigations were performed on a small population in specific geographic areas and were not representative of a general population, epidemiological studies on dilated cardiomyopathy are affected by many limitations. Another but substantial limitation of epidemiological studies conducted on this pathology depends upon the lack of standardized diagnostic criteria. The annual incidence of dilated cardiomyopathy represents a common and final phenotype of several disease entities and has been estimated at 5 to 8 cases per 1 lakh people. Current guidelines report a prevalence of familial dilated cardiomyopathy ranging from 30 to 50% of these cases, with 40% having an identifiable genetic cause. The prevalence of dilated cardiomyopathy has not been well studied in India compared to many Western countries in the world. However, the global burden of the disease data shows that there is a drastic increase in the incidence of dilated cardiomyopathy in India. There were 106,460 new cases of DCM in 1990 in India. In 1.5 decades, incidence increased massively to 150,000 new cases reported in the year 2005, and the spike in the incidence was consistent because 207,000 new cases were reported in the year 2019. This data clearly indicates the massive increase in the incidence of dilated cardiomyopathy in the past 3 decades in India. Although it is difficult to ascertain whether this increase in the incidence of dilated cardiomyopathy is highlighted because of the advanced detection systems, but the increasing incidence of dilated cardiomyopathy in India is alarming and has emerged as a major public health problem in the current scenario. The frequency of dilated cardiomyopathy in special groups, these include male to female ratio between 1 is to 1.3 and 1 is to 1.5, white to African Americans ratio of 1 is to 2.45, and a familial forms consisting of 30 to 50% of the disease. Moving on to pathophysiology, the hallmark pathophysiological features of dilated cardiomyopathy is systolic dysfunction of the left or both ventricles. Reduced sarcomere contractility increases ventricular volumes to maintain cardiac output through the Frank-Starling mechanism, producing the thin-walled dilated LV appearance that is observed in overt dilated cardiomyopathy. Frank and Starling demonstrated that increased ventricular preload augments contractility, but excessive pressures and volume induces a plateau and then a reduction in myocardial contraction. Abnormal hemodynamics lead to further to left ventricular remodeling. Cardiac remodeling in response to an inciting myocardial insult or an underlying genetic abnormality has been classically considered the pathognomic aspect of the dilated cardiomyopathy. Ventricular remodeling in dilated cardiomyopathy. The term ventricular remodeling refers to alteration in the ventricular architecture with associated increased volume and altered chamber configuration driven on a histological level by a combination of pathologic myocyte hypertrophy, myocyte apoptosis, myofibroblast proliferation, and interstitial fibrosis. The pathologic LV remodeling is closely linked to activation of a series of neuroendocrine, paracrine, and autocrine factors, which are upregulated after myocardial injury and in the setting of increased LV wall stress and hemodynamic derangements. Contributing factors include the renin-angiotensin-aldosterone axis, the adrenergic nervous system, increased oxidative stress, and pro-inflammatory cytokines and endothelin. Both renin-angiotensin-aldosterone system inhibition and beta-adrenergic blockade have shown to markedly attenuate or reverse LV remodeling in patients with heart failure and LV dilation. Genetic pathophysiology. The wide variety of genes involved in pathophysiology of dilated cardiomyopathy gives an insight to think of dilated cardiomyopathy as a group of diseases instead of a single form of cardiomyopathy. Deficit in force generation, that is sarcomere dilated cardiomyopathy, mutations within genes encoding titin, myosin, actin, troponin, and tropomyosin result in the expression abnormally functioning proteins, thus leading to myocardial dysfunction and dilated cardiomyopathy. Sarcomere gene mutations are the most frequent causes of DCM, with truncating mutations in titin occur in 25% of end-stage disease and 15% of ambulatory dilated cardiomyopathy patients. Defects in nuclear envelope, that is laminopathies. These diseases are characterized by variable degrees of heart and skeletal muscle involvement. Mutations involve lamin AC and emerin coding genes. Dominant lamin AC mutations occur in approximately 6% of dilated cardiomyopathy cases and are far more common in dilated cardiomyopathy with conduction systemic disease. Deficit in force transmission, that is cytoskeletal cardiomyopathies, mutations involving protein membranes of cytoskeletal apparatus like filaments, dystrophin, desmin, D-cycloglycan, and vinculin are responsible for muscular dystrophies which are often associated with dilated cardiomyopathy. Filament C truncation variants are associated with severe arrhythmogenic dilated cardiomyopathy phenotype in the absence of overt skeletal muscle disease. Deficit in protein post-translational modification glycosylation process cardiomyopathies manifesting as syndromic conditions with hypertrophic phenotype and as non-syndromic dilated cardiomyopathy phenotype. Impaired cell-to-cell adhesions, that is desmosomal cardiomyopathies, mutations in genes encoding desmosomal proteins are responsible for arrhythmogenic right ventricular cardiomyopathy and also for dilated cardiomyopathy with a prevalence up to 13% in a dilated cardiomyopathy cohort. We can see the various cardiomyocyte compartments contributing to genetically mediated dilated cardiomyopathies. Deficit in energy production, that is mitochondrial cardiomyopathies. They are characterized by defects in oxidative phosphorylation that result in deficient energy production in the form of ATP. They include hypertrophic, dilated, and LV non-compaction phenotypes. Calcium cycling abnormalities. These mutations in the genes result in increased SERCA inhibition and defective calcium reuptake with consequent reduction in contractility and heart dilatation. Ion channel abnormalities include channel genes like SCN5A and ABCC9 are typically associated with a variety of arrhythmic disorders. Other rare genetic mutations involve spliceosomal defects, epigenetic perturbation, protein misfolding disease, and RAS-MAPK pathway disruption. Moving on to molecular mechanisms of cardiac remodeling. Dilated cardiomyopathy is histologically characterized by diffuse fibrosis, compensatory hypertrophy of the other myocyte, and myocyte dropout. Myocyte hypertrophy is promoted by catecholaminergic stimulation, stretch activation of the integrins by myocyte and fibroblast, G protein mediated intracellular signaling, and microRNA networks. The rate of myocyte apoptosis and consequently progressive cell loss is increased in dilated cardiomyopathy. Neurohormonal systems include acutely reduced cardiac output or vascular underfilling leads to baroreceptor mediated sympathetic nervous system with elevation of heart rate, blood pressure and vasoconstriction. Although these changes maintain adequate cardiac output, at the end they lead to the vicious cycle. Catecholamines promote arrhythmias, myocardial ischemia, myocyte hypertrophy and apoptosis and cause different signal transduction abnormalities. Natriuretic peptides, these are the hormones produced by the heart, and important one being the B-type natriuretic peptide, proBNP, which is mainly released by ventricular myocardium. These are released in response to myocardial stress and act as a counter-regulatory hormones promoting natriuresis, diuresis, and vasodilation. Their plasma concentration raise in proportion to heart failure severity and are consolidated markers for poor prognosis in overt heart failure. Inflammation may also play a role in pathophysiology of dilated cardiomyopathy. Many studies have shown an increase in different inflammatory mediators, example tumor necrosis factor alpha, interleukin 1 beta, interleukin 2, interleukin 6, fast ligand, myocyte chemoattractant protein 1, and macrophage inflammatory protein alpha. Physiologic consequences of dilated cardiomyopathy include myocyte injury, leading to decreased contractility, leading to decreased stroke volume, which in turn increases the ventricular filling pressures, causes LV dilatations, and decreases the forward cardiac output. LV dilatation can in turn lead to mitral regurgitation. Increased ventricular filling pressures causes pulmonary congestion leading to dyspnea, orthopnea and rales, systemic congestion leading to edema, ascites and jugular venous distension. Forward cardiac output decrease lead to fatigue and weakness. Pathological consequences include four-chamber dilatation, varying degrees of interstitial fibrosis and myocyte hypertrophy. Functional atrioventricular valve regurgitation is common and often associated with normal epicardial coronary arteries. We can see here the gross histological specimen of a dilated cardiomyopathy versus a hypertrophic cardiomyopathy. Here we can see gross anatomy and histological specimen representative of dilated cardiomyopathy. Moving on to etiological classification, these include idiopathic causes, myocarditis, ischemic causes, infiltrative, peripartum, hypertensive causes, valvular heart disease, familial, inflammatory, infectious causes include viral infection caused by mainly picornavirus, COX, BCMV, and HIV. Rickettsial include Lyme disease, and parasitic diseases include Chagas disease and toxoplasmosis. Non-infectious causes include collagen vascular disease like systemic lupus erythematosus or rheumatoid arthritis. Toxins include alcohol, anthracyclines, and cocaine. Metabolic diseases include thyroid disease, mainly hypothyroidism, pheochromocytoma, diabetic mellitus, and acromegaly. Nutritional deficiency include thiamine, selenium, and carnitine deficiency. And neuromuscular diseases include Duchenne muscular dystrophy. We can see the percentage of various cardiomyopathies. In this, the idiopathic dilated cardiomyopathy almost contribute to 50% of the cases. Mm, Idiopathic dilated cardiomyopathy can be genetically determined or can be post-myocarditis, and acquired can be due to tachycardia, dysthyroidism, hypertension, alcohol, chemotherapy, autoimmune diseases, peripartum, or excessive beta adrenergic stimuli. Moving on to clinical presentation, most patients affected by dilated cardiomyopathy present between the ages of 20 to 60, but the disease can occur also in children and older adults. Furthermore, with respect to other heart failure etiologies, the comorbidity profile of DCM patients is very low. Finally, due to the frequent long-standing asymptomatic left ventricular dysfunction, these patients are often scarcely symptomatic for heart failure at diagnosis in spite of importantly remodeled left ventricle. Initial symptoms of heart failure were present in 80% of the patients with dilated cardiomyopathy. These symptoms include excessive sweating, orthopnea, fatigue after mild exertion. Abdominal discomfort, nausea, anorexia, and cachexia can be prominent in advanced cases. Circulatory collapse is the most severe manifestation of the congestive heart failure. Embolic events and rarely sudden cardiac death might be initial symptom, particularly in infants. Other symptoms include those related to ventricular or supraventricular arrhythmias, that is palpitations, syncope, and fatigue. In more recent years, however, the clinical presentation has somehow changed. In fact, the diagnosis often now occurs in asymptomatic individuals, mostly due to familial and sports screening programs. Despite recent advances in medical treatment, LV dysfunction associated with signs of congestive heart failure is characterized by significant mortality. Patients may progress through an asymptomatic phase of LV systolic dysfunction of various degrees from mild to severe before the development of overt heart failure. LV dysfunction has frequently a progressive nature, and that is the reason for increasing interest regarding its preclinical state. Most patients affected by dilated cardiomyopathy who present clinically with heart failure show symptoms and signs due to excess fluid accumulation, that is dyspnea, orthopnea, edema, pain from hepatic congestion, and abdominal discomfort due to ascites, sometimes associated with those due to a reduction in cardiac output like fatigue and weakness. In most patients with heart failure who require hospitalization, the reason for admission is volume overload. In clinical practice, four signs are commonly used to predict elevated filling pressures: jugular venous distension, abdominal jugular reflux, presence of S3 and or S4 and rails, and pedal edema. According to current international guidelines on heart failure, the patient with heart failure can be clinically assessed along two basic axes: volume status, dry or wet, and perfusion status, warm or cold, as useful guide to therapy. This approach has prognostic usefulness, particularly in assessing patients at discharge after admission for heart failure. For example, such patients discharged with a wet or cold profile experience worse outcomes compared to those discharged with warm and dry. In chronic presentations, symptoms are peripheral edema, abdominal distension, and anorexia may be more pronounced than dyspnea. Four major findings suggestive of severity of cardiac dysfunction and low output are resting sinus tachycardia, narrow pulse pressure, diaphoresis, and peripheral vasoconstriction. An irregular pulse is suggestive of atrial fibrillation, which frequently accompanies heart failure. Pulsus alterans is a sign of severe left ventricular systolic failure. A laterally displaced apical impulse that is past the mid-clavicular line is usually indicative of LV enlargement. An S3 gallop is associated with left atrial pressures exceeding 20 mm of Hg, 20 mm of mercury, and increased LV and diastolic pressures more than 15 mm of mercury. An apical systolic murmur is associated with mitral regurgitation, often present in these patients. Patients with chronic heart failure often develop secondary pulmonary hypertension. In patients with arrhythmic presentation, the onset of disease may be the presence of palpitation, syncopal or near syncopal episodes, or in some of them as sudden cardiac death. The spectrum of disease of dilated cardiomyopathy is very wide, ranging from asymptomatic LV dysfunction to arrhythmias to heart failure. Moving on to natural history, in the past, the prognosis of dilated cardiomyopathy was considered ominous, and the disease was frequently progressive to death due to heart failure or required heart transplant. By the time the patients were diagnosed, they often have severe contractile dysfunction and remodeling of the ventricles, reflecting a long period of asymptomatic silent disease progression. However, implementation of optimal pharmacological and non-pharmacological treatments have dramatically improved the prognosis of dilated cardiomyopathy, with an estimated survival free from death and heart transplantation up to 85% at 10 years. The improved outcomes in dilated cardiomyopathies are paralleled by a higher rate of LV reverse remodeling. In recent years, several studies revealed that almost 40% of the patients experience a significant left ventricular reverse remodeling when treated with evidence-based pharmacological and device treatments. Initially a compensatory process, the release of hypovolemic hormones such as renin, antidiuretic hormone, and norepinephrine eventually contributes to the progression of dilated cardiomyopathy, and of pharmacologic therapies that reduce this neurohormonal activation have been shown to promote left ventricular reverse remodeling. The process of left ventricular reverse remodeling may take up to 2 years following diagnosis. The following aspects evaluated at baseline and during follow-up have been demonstrated as influencing the course and the prognosis of the disease and the likelihood of left ventricular reverse remodeling in early stages. Right ventricular function at the diagnosis, function of the functional mitral regurgitation, left bundle branch block, the onset of atrial fibrillation during the follow-up, and the persistence of restrictive filling at 3 months. Natural history of dilated cardiomyopathy, the early prognostic stratification and continuous re-stratification during long-term and follow-up are fundamental in order to identify those at higher risk and of sudden cardiac death. Of the diagnosed patients, 15% of these can move on to apparent healing, 40% can have LV reverse remodeling, 30 to 40% can have progressive remodeling leading to refractory heart failure, and 10% of the patients can have sudden cardiac death. Diagnosis of dilated cardiomyopathy. Depends on the history, clinical examination, chest X-ray, 12 lead ECG, echocardiography, blood test, family and genetic testing, endomyocardial biopsy, cardiac CT scan or MRI, and cardiac catheterization. Associated history with the dilated cardiomyopathy. This can be chronic alcohol consumption, peripartum status of the patient, ischemic heart disease, malnutrition, hereditary involvement, that is, 3 generation of family history is essential. Diabetes mellitus, endocrine disorder, valvular disorder like MR and AR. Clinical manifestation, as earlier discussed, may affect all age group, may be asymptomatic. The onset can be insidious, but sometimes symptoms of heart failure can occur suddenly. Dyspnea, palpitation, chest pain can be accompanied with dizziness, syncope. Patients may also present with cerebrovascular accident like hemiplegia and paraplegia. Patients may also present with systemic embolism, and in infants and younger children can have respiratory symptoms and failure to thrive. The signs of dilated cardiomyopathy, these include sinus tachycardia with irregular in atrial fibrillation and bradycardia in complete heart block, low BP and narrow pulse pressure. JVP will be elevated, apex will be shifted, it will be forceful and ill sustained. P2 may be palpable due to pulmonary hypertension. There may be parasternal lift. On auscultation, S1 S2 will be soft. Pansystolic murmur at mitral and tricuspid are heard, and S3 and S4 are common. Other peripheral signs include liver enlargement, liver can be tender and pulsatile, edema at the dependent parts, lung base will be basal crepitations will can be present. Other signs of systemic and pulmonary embolism may be found. The American Cardiologist and AHA, American Heart Association Heart Failure Evaluation Guidelines, give class 1 and class 2 recommendations in dilated cardiomyopathy. These include laboratory studies include blood count, urinalysis, electrolytes, renal function test, glucose and LFT. That's class 1 recommendations. Thyroid stimulating hormone as class 1, then ferritin, TIBC and ferritin as class 2A. Urinary screening for hemochromatosis as class 2A, measurement of ANA, rheumatoid factor, urinary VMA, and metanephrines in selected patients as class 2A recommendations, and HIV as class 2B recommendations. Electrocardiogram as class 1 recommendation, chest X-ray as class 1, and echocardiogram and Doppler as class 1 recommendations. ECG findings include sinus tachycardia or bradycardia, low voltage ECG, left ventricular hypertrophy, right or left atrial hypertrophy, pseudo-infraction pattern that is deep but narrow Q waves might suggest you of anteroseptal AMI, shallow inversion of T wave, left bundle branch block, right bundle branch block, or left anterior fascicular hemi block. Bifascicular or trifascicular block may be present, or atrioventricular block can be present. Chest X-ray findings include cardiomegaly, stimulating pericardial effusion or multivalvular disease or ischemic cardiomyopathy, pulmonary edema with curly B lines, with pleural effusion may be present. Pulmonary infection is not uncommon, usually no enlargement, so single right heart border is seen, usually no calcified valve and normal aorta. Echocardiography features include 2D echo features include all four chambers can be dilated. LV wall will be thin with hypokinesia. M-mode on echo of dilated cardiomyopathy can show valve normal morphology with reduced exertion. EPSS is increased. Mitral valve shows penguin appearance in the seashore. Color Doppler will show functional MR and TR with trivial AR. Indications and pitfalls of endomyocardial biopsy. The indications include suspected myocarditis in patients with high-risk syndromes like cardiogenic shock, refractory heart failure, or left ventricular dysfunction with ejection fraction of less than 40% despite conventional therapy, persistent life-threatening and ventricular arrhythmias, suspected giant cell myocarditis or eosinophilic myocarditis, suspected cardiac sarcoidosis, suspected end-stage hypertrophic cardiomyopathy, suspected infiltrative cardiomyopathy, out-of-hospital cardiac arrest without significant coronary artery disease, monitoring cardiac transplant rejection status, and histological diagnosis of cardiac tumors. The pitfalls for endomyocardial biopsy include diagnostic accuracy depends on the expertise of the operator who performs the procedure, timing of the procedure related to beginning of the patient's symptoms, biopsy site that is LV or RV, number of bioptic samples, expertise of pathologists who analyzes the samples and patchy diseases. Here we can see the right ventricular biopsy. Moving on to cardiovascular magnetic resonance, CMR imaging is considered the gold standard for assessment of ventricular volumes and ejection fraction, enabling confident diagnosis of dilated cardiomyopathy in borderline cases and improving the characterization of the disease severity in patients with known LV dysfunction. Another crucial aspect of CMR is tissue characterization that can be useful in diagnosis of specific forms of dilated cardiomyopathy. The identification of myocardial edema in T2 weight images suggestive of active myocarditis and late gadolinium enhancements representing replacement fibrosis. The presence of late gadolinium enhancement in dilated cardiomyopathy carries important prognostic implications in terms of low probability of LV reverse remodeling and increased risk of sudden cardiac death. Emerging CMR techniques include specifically T1 mapping, provide assessment of the interstitial fibrosis, and could represent the future tool for early diagnosis and risk stratification of dilated cardiomyopathy. Here we can see late gadolinium enhancement imaging in case of a DCM in a fourth chamber view. Moving on to computed tomography, it is mainly used to test for the presence of coronary artery disease, but may also play a role in evaluation of cardiac volumes and function, characterization of the type of cardiomyopathy, and treatment planning. Cardiac catheterization is limited to right heart catheterization to selected cases such as in patients with advanced disease who are candidates for cardiac transplantation due to its limited importance in diagnostic workup. However, it is pivotal for prognostic stratification. Okay, moving on to management. The aim of management in dilated cardiomyopathy is the prevention of heart failure, mainly by drug therapy or mechanical assist devices, or ultimately heart transplant, prevention of sudden cardiac death, and prevention of thromboembolic complications. The current management and treatment guidelines and recommendations by European Society includes firstly screening programs, the familial screening programs of the first degree relatives if a specific gene mutation is identified in the proband, then family history of sudden cardiac death in a first degree relative. These are recommended from age 10 to 12 years. Sports activity screening for all young competitive athletes by history, physical examination, and ECG, and for all young competitive athletes with history and physical examination. These are recommended by both European Society and by American Society. Pharmacological treatment. ACE inhibitors are recommended in patients with asymptomatic LV systolic dysfunction in order to prevent or delay the onset of heart failure. These are class 1B recommendations. Uh, then angiotensin receptor blockers are recommended in patients with symptomatic LV systolic dysfunction in order to reduce heart failure, hospitalization, and death, and unable to tolerate an ACE inhibitors. These are class 1B recommendations. Beta blockers in patients with symptomatic LV systolic dysfunction in order to reduce heart failure, hospitalization, and death. These are class 1A recommendations. Then aldosterone receptor blockers, patients with LV systolic dysfunction still symptomatic with an optimized dosage of ACE inhibitors and beta blockers in order to reduce heart failure, hospitalization, and death. These are also class 1A recommendations. Sacubitril valsartan, patients with LV systolic dysfunction, EF less than 35%, still symptomatic, NYHA grade 2 or 3 with an optimized dosage of ACE inhibitors or ARBs beta blocker in order to reduce heart failure, hospitalization, and death. These are class 1B recommendations. Ivabradine in patients with LV systolic dysfunction, EF less than 35%, still symptomatic in sinus rhythm and resting heart rate more than 70 beats per minute with an optimized dosage of ACE inhibitors or ARB beta blocker in order to reduce heart failure, hospitalization, and cardiovascular death. These are class 2A recommendations. Diuretics to reduce symptoms and signs of congestions are recommended as class 1B. Hydralazine and isosorbide dinitrate with symptomatic LV systolic dysfunction in case of intolerance or contraindications to ACE inhibitors ARBs in order to reduce mortality. And in LV systolic dysfunction with EF less than 35% and still symptomatic NYHA class 3 and 4 with an optimized dosage of any ACE inhibitors and beta blockers. These are class 2A and 2B recommendations. Moving on to non-pharmacological treatment, implantable cardioverter than 35% and symptomatic NYHA 2 and 3 despite 3 months of OMT in order to reduce sudden cardiac death and all-cause mortality. These are recommended as class 1B. uh, Cardiac resynchronization therapy in patients with LV systolic dysfunction with EF less than 35% in sinus rhythm and symptomatic despite in order to reduce morbidity and mortality. QRS duration of more than 150 milliseconds with lead bundle branch block are class 1A recommendations. QRS duration of 130 to 150 milliseconds with left bundle branch block are recommended as 1B, and QRS duration of with more than 150 and non left bundle branch block are recommended as 2A, and QRS duration of more than 130 to 150 as recommended as 2B. IABP or VA ECMO are recommended in refractory acute heart failure or cardiogenic shock with short-term uh, mm, mechanical circulatory support depending on patient age, comorbidities, and neurological function. These are recommended as class 2B. Mitral clip in heart failure with moderate to severe secondary functional mitral regurgitation, inoperable or high surgical risk in order to improve symptoms and quality of life. These are recommended as class 2B. LVAD in patients with LV systolic dysfunction with EF less than 35% end-stage heart failure despite a device or eligible for heart transplant in order to improve symptoms and reduce the heart failure hospitalization and premature death as bridge to transplant. These are recommended as class 2A, and patients with LV systolic dysfunction with EF less than 35% end-stage heart failure in order to improve the symptoms and reduce heart failure hospitalization and premature death as class 2A B. Heart transplant in patients with LV systolic dysfunction, EF less than 35% end-stage heart failure despite or in the absence of contraindications in order to increase survival, exercise capacity and quality of life. These are recommended. So management and escalation therapy for heart failure in dilated cardiomyopathy, starting with first with the familial and activities, sports activity screening, moving then establishing a diagnosis and ruling out the differential diagnosis, starting with medical pharmacotherapy with EFs better more than 35% and in EFs less than 35% with ICD, CRT or mitral clip, and finally with inotropic supports VA, ECMO, LVAD, and heart transplantation, and lastly palliative care. Implantable cardioverter defibrillator. Prophylactic implantation of ICD is a class 1 recommendation for patients with non-ischemic dilated cardiomyopathy, symptomatic heart failure with NYHA class 2 and 3 and EF less than 35%. Among patients with non-ischemic dilated cardiomyopathy, these indications are based on two randomized trials, the DEFINITE and the SCD HEFT trial, which showed a trend towards a reduction of mortality in the ICD arm. In patients with documented arrhythmias or history of unexplained syncope should be treated aggressively, usually with an ICD. Prevention of sudden cardiac death with an ICD is efficacious. Cardiac resynchronization therapy, use of biventricular pacing had been proposed in pharmacological refractory heart failure patients with intraventricular conduction delay to optimize cardiac performance through epicardial and then transvenous electrodes. Since then, many trials have demonstrated that CRT is inappropriately selected patients reduces mortality and morbidity and improves systolic function, symptoms, and quality of life. Reverse remodeling is one of the most important mechanisms of actions of cardiac resynchronization therapy, but not all patients respond successfully. Patients with non-ischemic etiology have greater improvement in LV function and decrease in NYHA class after CRT. A companion study demonstrated for the first time a better outcome in patients with implanted with CRT plus a defibrillator with advanced heart failure and a QRS interval more than 120 milliseconds than those under pharmacological therapy alone. Surgical treatment options for dilated cardiomyopathy. These include mitral valve repair. Mitral regurgitation in cardiomyopathy has two major mechanistic components: annular dilatation as a part of overall LV enlargement and abnormal separation of the papillary muscles. Boiling and colleagues reported a hospital mortality of less than 2% and 1 year survival of 82% following mitral valve annuloplasty using an undersized flexible ring in the presence of severe LV systolic dysfunction with preoperative EF ranging from 8 to 25%. Patients experienced improved NYHA class EF and exercise oxygen consumption and reduced end systolic and end diastolic volumes. In absence of acute cardiac decompensation or chronic inotropic dependence, surgical mitral valve repair can be considered in patients who remain symptomatic despite optimal medical therapy when mitral regurgitation is severe. Here we can see how abnormal separation of papillary muscles as a cause of mitral regurgitation in dilated cardiomyopathy. Moving on to partial left ventriculectomy. In 1996, Batista introduced the concept of surgically reversing the remodeling process of in dilated cardiomyopathy with a procedure termed partial left ventriculectomy. Partial left ventriculectomy consists of full thickness LV free wall resection between the papillary muscles extending from the mitral annulus to the LV apex. In the presence of mitral regurgitation, the mitral valve is repaired or replaced, usually through the ventriculectomy incision. The basis for the operation was the Laplace law, which relates wall tension to chamber radius. It was reasoned that reduction in LV size would improve cardiac function. The potential limitation of this procedure is that it removes functioning, though weakened myocardium. Diagrammatic representation of partial left ventriculectomy. The indications include, as originally described, partial left ventriculectomy was indicated for patients in NYHA class 4 heart failure from dilated cardiomyopathy. Currently, in countries where cardiac transplantation is available, this procedure has been largely abandoned. However, in countries or regions without access to these more complex and expensive therapies, these procedures may be advisable for patients with marked LV dilatation and diastolic dimension of 7 cm or more and class 4 heart failure despite optimal medical therapy. The results of this technique, although the procedure initially generated considerable enthusiasm as an alternative to cardiac transplantation, surgical mortality was considerably higher than after transplantation, and subsequent composite freedom from death need for ventricular assist support and cardiac transplantation was low at 2 years. Despite the lack of current interest in this procedure, good functional results can be obtained in some patients. Alternative therapies include dynamic cardiomyoplasty. Dynamic cardiomyoplasty is use of an electrically stimulated skeletal muscle that is wrapped around a part of the heart to augment or restore contractility of the ventricles. It was introduced experimentally by Kantrowitz and McKinnon in 1959 and developed for use in humans by Carpentier and Jacques in 1958. The latissimus dorsi muscles is transferred as a muscle flap through a window in the chest wall made by partial removal of a rib. It is used as a wrap around the heart for reinforcement or as a substitute for a defect in the ventricular wall. Electrodes are implanted on the muscle flap and connected to an electrical simulator which paces contractions synchronously with myocardial contraction. Long-term studies of patients having cardiomyopathy have shown improvement in quality of life and functional class following dynamic cardiomyopathy. However, clinical improvement has not correlated with changes in LVEF or cardiac output. Consequently, dynamic cardiomyopathy has not found a place in routine treatment of cardiac failure. Ventricular shape change and constant devices. Chaudhary and colleagues used a prosthetic jacket of knitted polyester mesh to provide a passive LV constraint in a canine heart failure model. A prosthetic jacket prevented progressive LV remodeling and abolished functional mitral valve regurgitation. This led to Akron cardiac device support for use in humans. To date, no ventricular constraining device has received FDA approval in the United States, and supplemental trials are in progress. Direct cardiac or aortic compression devices. Devices to assist the failing heart by direct compression of the heart to shift the end systolic pressure volume relationship or aorta have been designed to avoid blood foreign surface interaction of the assist device. Direct cardiac or aortic compression devices have the advantages of simplicity of application during unstable circulatory condition and ease of removal after recovery from heart failure or a transplantation. The cardio support system, cardiotechnology spine brook, is a cuff-like structure that surrounds both ventricles from apex to atrioventricular groove. It is applied under negative pressure of minus 200 mm of Sg to provide a vacuum seal. Compression bladders are inflated and deflated in synchrony with cardiac contraction timed from epicardial electrocardiogram electrodes. The heart booster is a cuff-like device consisting of several parallel compression tubes covering both ventricles and held in place with a surgical adhesive. A hydraulic drive system fills and empties the compression tubes. The Cantrovis CardioVAD by LVAD Technologies is an experimental system operating on the principle of diastolic augmentation like an intra-aortic balloon catheter and pump. These compression systems are in development phase and are intended for a short-term use less than 7 days for any cause of cardiogenic shock. Moving on to advanced heart failure, mechanical circulatory support, and functional mitral regurgitation correction, heart transplantation, and palliative care in dilated cardiomyopathy. 0.5 to 5% of patients respond poorly to recommended therapy and can develop severe chronic advanced heart failure with a wide scenario going from refractory deterioration up to cardiogenic shock. Mechanical circulatory support devices can be used in critically ill heart failure patients who can't be stabilized by medical therapy alone. Their goals are to unload the failing ventricle and maintain an adequate end organ perfusion. Short-term mechanical circulatory supports, that is few days to weeks, are the system of choice in patients with acute heart failure or cardiogenic shock. These mainly include intra-aortic balloon pump and veno-arterial extracorporeal membrane oxygenation, that is VA. They permit to stabilize hemodynamics and gain time for recovery or reevaluation for the possibility of either a more durable mechanical circulatory support or heart transplant. In a more chronic setting, functional mitral regurgitation is common finding in patients with dilated cardiomyopathy and left ventricular impairment and is associated with poor prognosis. In recent years, percutaneous correction of mitral regurgitation with a Mitra clip system has been established as an alternative to treatment option for surgically high-risk patients with degenerative and functional mitral regurgitation. Heart transplantation is well-recognized treatment that significantly increases quality of life survival for eligible patients with advanced heart failure, severe symptoms, poor prognosis, and no remaining alternative choices. Unfortunately, suitable donor availability is extremely limited, and in these cases, implantable left ventricular assist device, that is LVAD technology, has improved considerably. Historically used only for short periods as a bridge to transplantation, nowadays it is being used increasingly as a permanent treatment or a destination therapy. Advanced ages, multiple comorbidities, and poorly controlled symptoms characterize the heart failure terminal stage. In this setting, symptoms management and emotional support of the patients and their family are the principal components of palliative care in advanced heart failure in order to improve the quality of life. Use of ventricular assist devices for advanced heart failure. The development of mechanical circulatory support was driven initially by high mortality associated with cardiogenic shock and need for support of patients who were unable to wean from cardiopulmonary bypass following cardiac surgery. Initial left ventricular assist device designs were intended to simulate the heart function by creating a pulse with a physiological one-third systole and two-third diastole cycle. Limitations of pulsatile pumps included their large size and weight, but ultimately the poor durability of these pumps became the primary limitation as they usually failed within 2 years of use. This led to development of continuous flow design which now represent nearly all LVAD used today. The current continuous flow LVADs are similar in function with five main components: an inflow cannula, a pump, an outflow cannula, a percutaneous driveline, and an electrical controller. The inflow cannula is inserted into the apex of or diaphragmatic surface of the LV, and the outflow cannula is anastomosed to the aorta, usually the ascending portion. Blood exits passively through the LV into the propulsion chamber of the VAD and is then actively propelled into the arterial circulation. Continuous flow pumps, unlike the original pulsatile system, ideally work in parallel with the native heart, acting as a true assist devices by partially unloading the failing heart and restoring the Starling's response and relieving heart failure symptoms. There are two types of continuous flow pumps currently available for commercial use: axial and centrifugal design. The first continuous flow LVAD to be approved by the Food and Drug Administration was the axial design HeartMate 2 by Abbott, which has only one moving part, an axial electromagnetic rotor that spins on ruby bearings located at either of the assembly. This pump is implanted in preperitoneal space. The second type of continuous flow LVAD is hardware uses centrifugal flow design by Medtronic and HeartMate 3 by Abbott are smaller and flatter and therefore could be implanted within the pericardium, eliminating the need for pump pocket and its associated infection risk. The flat design of the hardware also allowed implantation of the diaphragmatic surface of the heart, allowing for both long-term like right-sided and left-sided support. Here we can see the Hartward totally intrapericardial LVAD and HeartMate 3. Candidate selection for LVAD. It is clear that the candidate selection has the greatest impact on success with LVADs. Current American College of Cardiology, American Heart Association guidelines define the indications for LVAD as advanced systolic heart failure with LV ejection fraction less than 25% and NYHA class 3 and 4 functional status. The criteria also require either high predicted 1 to 2 year mortality or dependent on continuous intravenous inotropic support. The selection criteria for LVAD includes patients that for size, social condition, advanced age, advanced disease state, etc., would not be considered transplant candidates at the time of implant. Risk factors include risk factors for a worse outcome include patients who have been documented to be non-compliant with medications or office appointments or cannot quit smoking, drinking, or using drugs. Other risk factors include those who cannot ambulate because of severe chronic obstructive pulmonary disease or symptomatic peripheral vascular disease without suitable revascularization options. The complications mainly include gastrointestinal bleeding, device thrombosis, RV failure, infection, stroke, and ventricular arrhythmia. Causes of death post LVAD. The greatest cause of death in the first 6 months following LVAD implant is a multi-system organ failure, RV failure, and stroke, ischemic or hemorrhagic. The need for RV assist device at the original operation is the biggest contributor to early mortality. Other risk factors include dialysis, chronic pulmonary disease, peripheral vascular disease, and renal dysfunction, as well as overall nutritional state. Over time, post-LVAD stroke dominates as the major cause of death. Outcomes by severity of heart failure. The severity of heart failure and overall acuity of patients at the time of LVAD implant has a profound effect on survival. The roadmap trial, risk assessment, and comparative effectiveness of left ventricular assist device and medical management was a prospective observational study of 200 non-inotrope dependent patients who were either managed medically or underwent LVAD implant based on the preference of the patient and the providers. The study showed LVAD therapy was superior to current medical management. Although patients who opted for LVAD were sicker at baseline, the primary endpoint, survival with improvement in 6-minute walk distance by more than 75 meters at 12 months, was achieved in 39% of the patients on LVADs versus 21% on medical management. The newly emergent treatment for dilated cardiomyopathy, these include immunomodulation therapy, gene therapy, and cell therapy. Moving on to prognosis, the course of the disease is progressively downhill, although some patients may remain stable for years. Treatment of heart failure may result in temporary remission, but relapses are common and in time patients become resistant to the therapy. Initially, prognosis of survival beyond a year was poor, very poor. 50% die within 2 years of diagnosis and 10% only may recover. 25 to 40% could survive for 10 years. In the last decades, prognosis of dilated cardiomyopathy has dramatically been improved. 10 years of follow-up, the survival free from heart transplant rate is beyond 85%. The data from the Heart Muscle Disease Registry of the registry perfectly highlight the results over time. Once believed as an irreversible disease, dilated cardiomyopathy has rapidly become a more treatable condition thanks to the advancements that were made. Thank you.
Good, Shreyas. It's a fairly comprehensive but an extensive presentation.
Thank you, sir.
The only thing is that you may not be able to reproduce all this in a paper in your answer sheet, which will be only for 18 minutes. So you have to sort of concise that whole thing. I liked your first slide where you had all the headings. So you have to expand on those headings with just a couple of lines for each of them. And especially when you talk about the treatment part, you probably have to uh, say a few little more things on those things, the surgical procedures.
Okay,
Now,
sir.
with your genetic and molecular causes, it was a good presentation, but I'm sure most of us will not remember all those various things. So you just have to have a basic generalized idea, and when you say that these are the most common causes sort of thing in a line or two. And a word on endomyocardial biopsy. Endomyocardial biopsy is usually done through the right side, I mean from the venous side, and basically from the right ventricle, because it has a lot more trabeculation and muscular this thing for biopsy, amenable for biopsy. Left
Okay, sir.
ventricular biopsy is generally not commonly used. And it is detrimental because you may cause a rupture or ventricular septal rupture or a free-wall rupture. So that is a problem. And you
Okay,
may damage the, if you are inadvertent, you may damage the papillary muscle and then cause disastrous results.
okay, sir.
Now coming to this thing, our own, like Jairaj sir always says, what is our experience in our institution? You see, basically, you must understand that most of the treatment for dilated cardiomyopathy is medical, and surgical management is very, very low or only in the end stages. So you must know what is the number of patients treated for dilated cardiomyopathy in our institution on the medical side, and how many
Mhm.
of them are sort of referred for surgical management as a percentage, and what was the outcome. So it would be a good addition to add onto your presentation.
Yes, sir. Yes.
Now coming to the the surgical procedures, the two procedures that you mentioned, Batista and cardiomyoplasty, both of them have been given up almost totally. And in fact, in the early 90s, Batista came and demonstrated a few cases here as well as a this thing, live surgery. And although the patients uh, recovered initially, they came off bypass, but subsequently within about 6 to 12 hours, most of them died. The reason being, in the pathophysiology in dilated cardiomyopathy is a conical left ventricle, which has a squeezing motion, is converted into a globular left ventricle. That was what causes the um, systolic dysfunction. So
Yes.
Batista thought that, you can just narrow down this thing and then chop off a bit of ventricle and make it into a cone, which was, the concept might have been good, but it was not standardized, because whenever anybody asked him how much and how will you uh, mm, excise the muscle, he would say he would pass it off saying that I just eyeballed it. That was not going to be scientifically accepted. And in fact, Dr. McCarthy has published a paper which has sort of uh, refuted the concept of Batista's operation, and that is why it went out of vogue. Similarly, cardiomyoplasty, left ventricular latissimus dorsi. You must remember latissimus dorsi is a skeletal muscle, and it has to be trained to contract rhythmically with a pacemaker. And a skeletal
Yes.
muscle is prone for fatigue.
Fatigue.
If you remember from your physiology days in MBBS, skeletal muscle is not meant to contract continuously as against cardiac muscle. So that also sort of got into trouble, and then cardiomyoplasty was also generally given up. And of course, the Acorn device and other things that was done, that they also did not work well, because they started restricting the filling, ventricular filling, and then there was fibrosis from the device and the myocardial muscle area, and then that causes contraction abnormalities. So in fact, it was initially recommended or highly popularized by one of my juniors from St. John's, Jai Shankar Raman, but then I think those things are also given up. I suppose the present day things for surgical management is, apart from your uh, pacemakers and defibrillators and the mitral clip, it is LVADs and uh, transplant. So that the 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 choice and the timing of the patient's procedure has to be uh, well established, and it varies from center to center. So it would be nice if you had a little statistics of our own, because we do quite a few things here. And then, being a major
Yes, sir.
surgical center, it would be nice to have our own data, so that it could be also used as a paper for presentation in any conferences, or even publish as an article. So these are things that some of you can look into it and then work on that.
Yes, sir.
Right?
Yes.
So, and as I initially told you, it is very difficult to reproduce all this in one paper. Remember, you have to write an answer in 15 minutes with a
Yes, sir.
3-minute margin. So the basic, you have to just write down on your headings and then expand on them, and maybe or use your flow diagrams. Your flow diagrams were very good, actually. And if all of you can sort of learn that, and then reproduce, understand the flow diagram, you can create your own flow diagram in the answer booklets. So you have to time,
Right.
because ultimately you are pressed for time in answering your questions. And I always told all of you all, you have to attempt all questions. Otherwise, You may miss if you don't attempt a question at answer at all, you'll get 0 marks. But if you write something, you might get 2 or 3 marks out of 10. So
Yes.
that makes a lot of difference for your passing things. So you must write your answers. You must time management is extremely important in answering in an exam. Okay,
Yes, sir. Yes.
sir, you got something to say, sir?
Oh, I don't know much about this. The only thing is that modern days in most of the cardiac hospitals, there's a heart failure treatment, special doctors who do this treatment. And you have exhaustively treated the initial part of the genetic, all those things. You mentioned many of the drugs. You must say what is the most prominent drug and what is commonly used. And you didn't stress on the neprilysin inhibitor, like the sacubitril valsartan combination, which I think in the European thing you may mention as 1B or so. Anyway, that's a common drug. So you should that. And then periodically, in most of the heart failure centers, these patients are admitted for a short while and they're given inotropic support for some time. Usually, with that treatment, the remodeling reverses, partly reverses, and they are discharged. So they're constantly under the care of a heart failure treatment. So you mentioned all the drugs, but you should have mentioned what the commonly used drugs and how they are used.
Okay, sir.
Beta blocker. You mentioned the indications of beta blockers, the ACE inhibitors, ARB, and the neprilysin inhibitor like sacubitril. But that's good. Then the other thing is, as Krishna said, the you said in some countries where LV had not available, heart transplant not available, the Batista operation can be done. But I think that's not really true because the long-term survival of Batista is very bad, so it's not done.
Okay, sir.
Similarly, the dynamic cardiomyoplasty with that is also given up here. I know in the 90s it's an enthusiasm in India to do that, but that's also given up. The account wrap is absolutely given up. Nobody does that. I don't think FDA give even permission to do that. I think the Jayaraman moved from USA to Australia and trying to do that. That's also given up. The other thing you should have mentioned, as I always said, the starting of the LRAD in this hospital, a team from Minnesota University came here many years ago. They did 4 cases,
Okay.
LRAD. And I think 3 of them survived, and one of them, I think there is some mechanical block in that. So they reoperated on that. At that time, actually, the reverse remodeling had already occurred, and they just removed the LVAD without adding another one. The patient survived for some time later because by that time, the reverse remodeling had already occurred.
Okay.
The other thing is that I mean, you could have referred and found out how often they are doing that and what is the LVAD. The HeartMate 2 and HeartMate 3 has come, but I think in this hospital, they have been doing mainly HeartMate 2, that's what I
Yes,
think.
sir.
Should have referred that. The complications of biventricular assist devices, the uh, ICD, the implantable cardiovascular defibrillator. How is the CRT done? What is CRT?
Uh, so mostly they in CRT they will do biventricular pacing, sir, in a synchronized manner, so that any arrhythmias are avoided and feeling mostly
Who
the
did that? How is it done?
So like pacemaker implantation through
Yeah,
venous access. And
yeah. How? One electrode goes to the apex of the right ventricle. Where does the second one go?
so atrial, sir. Atrially.
Atrial. No, it's a biventricular vein.
Ventricle, sorry. Yes, sir.
The initial the procedure is through the coronary sinus. The second catheter goes to the posterior intraventricular vein, which is in
Okay.
the intraventricular groove, and go down. And that's
Ah,
the
yes, sir.
one facing the left ventricle. And then the right ventricle is placed at the apex of the, as usual, so putting like a pacemaker. But I remember initially in many cases, the cardiologists were not able to maneuver it into the apex of the left in the interventricular groove. So that was done by surgery, epicardial for
Okay.
the left ventricle and endocardial for the